She. It's a pleasure to be with you all today. I apologize. Of course, it is not in person. I think we're all used to that at this point. So bear with me with my technology. If I do anything that you can't see or follow, please just let me know. Today, as she mentioned, I'll be presenting some data from the ALIVE study. And we're really today going to focus on digging into some data on the temporal trends in substance use nationwide, as just to set the stage for some of the research that I'll present from the ALIVE cohort. So I also just want to mention that some of these findings are preliminary, and so I do appreciate hearing any feedback that you might be able to share with me once we get to the question portion of today's talk. So can you see this slide? We're good? Okay, great, thank you. So this graph from CDC depicts a story that I think we all probably know quite well at this point. It shows the age-adjusted mortality rates in the US and the steep increases that have continued nationwide since the 1990s. In 2017, which is the last year depicted here, there were just over 67,000 deaths in the US due to overdose. And the age-adjusted death rate was 21.7 per 100,000. While the numbers did drop slightly in 2018, which is the year for which we do have the most recent data, it's not shown here on the slide, we do know that there's evidence now of some increases in 2019 and then potentially a sharp rise in 2020 that coincided with the COVID-19 pandemic. In 2018, the states with the highest rates of overdose deaths were West Virginia, Delaware, Maryland, Pennsylvania, Ohio, and New Hampshire. So opioids are the main driver of drug overdose deaths, with 70% of deaths in 2018 related to opioid use. We now know that embedded within this steep incline in deaths due to overdose is what the CDC has explained as 3 distinct waves that are fueled actually by different opioids. The first wave of the opioid epidemic began in the 1990s and was driven largely by prescription opioid use. This initial wave of overdose deaths resulted from overprescribing of painkillers, extreme and misleading marketing by pharmaceutical companies, and limited regulation. Since greater controls have been put into place, these deaths have actually leveled off. The second wave of deaths, you can see, begins around 2010. And this wave was fueled by increased deaths due to heroin use. Many hypothesized actually that as the prescription opioids underwent more strict control, many users actually turned to cheaper and more widely available heroin. The third wave, characterized by CDC, began in 2013. And this is when deaths due to synthetic opioids eclipsed deaths due both to prescription opioids and heroin. Synthetic opioids, and fentanyl in particular, are illicitly manufactured and imported into the US, mainly from China, either directly through the Postal Service or indirectly through distributors in Mexico. Synthetic opioids are inexpensive to produce, and they're exponentially more potent than other opioids, meaning that they're more easily distributed in smaller quantities. Critical to understanding the reasons behind the surges in deaths is the idea that synthetic opioids are being cut into the drug supply and contaminating many other drugs that are in the illicit drug market. And for the individual user, this means that it's nearly impossible to know the quantity of synthetic opioid that is in the drugs that they are using. With a lethal dose constituting as little as 1 milligram, this means that even a very experienced user could very easily get the wrong dosage. Sorry about that. I'll work out my technology at some point over 2021, maybe. Okay, so here I'm presenting a recent paper that was published in Rural Sociology in 2019. And it shows how these 3 waves have hit different parts of the US as they have unfolded. So the data presented here goes from 1999 to 2016, and it's disaggregated by rural versus urban regions. So you can see the variation in deaths across these regions by time period and by substance. What is demonstrated here is that the initial wave of our current opioid crisis was most profoundly felt in rural communities across the US. The second two waves, again, fueled largely by heroin and synthetic opioids, were felt much more strongly in urban communities. Note that here you can also discern that deaths from prescription opioids are actually declining in all regions. While there's a less clear trend for heroin-related mortality, there is a clear upward trend for deaths due to synthetic opioids across all regions, though we do see that this is most profound in urban areas. Note also that, as I mentioned, the deaths depicted here only go through 2016, but we have seen a continuation of these trends nationally since that time. So then what's missing from our national conversation, I think, is the discussion of the dramatic increases that we see in deaths in urban areas. The popular press is predominantly focused on the rapid rises that have occurred in rural and suburban areas of the US. And then, of course, related to this is a discussion about race. So this headline, I think, is a bit of an anomaly and kind of captures what I'm trying to say here. It's called Separate, Unequal, and Overlooked. And it's from the US News and World Report, of all sources. And it details a story of overdoses that have long been an issue in cities like Chicago. So this idea that something even began in the 90s, I think, is something that folks who've been working in urban areas really kind of contest. Historically, you can go back to the 1960s and the 1970s when overdose mortality was related to heroin use, and it was higher then among Blacks. And the rates of increases were similar for both Black and white populations into the 1990s. The media, however, I think has really highlighted the rapid increases in the white population, of course, from 1999 through 2010. Where by then the opioid mortality rate was 2 times higher for whites than for Blacks. Again, during this period, the opioid epidemic was driven largely by prescription opioids, but when we look from 2010 to the present, mortality increases were driven by heroin and more recently synthetic opioids. We see increases more similar across both populations. So there has been a lot discussed about this in the academic press in terms of the responses to these various epidemics and how racialized the responses are. The characterization of addiction, I think, varies very explicitly depending on which opioid epidemic we're talking about. Policy responses have been drastically different you can think back to the 1980s war on drugs policies from prior decades. And this really contrasts a lot, I think, with the model of addiction that we see portrayed in the popular media now, which purports that addiction is a disease and that this has really followed the initial wave of overdose deaths that were due to prescription opioids in rural and suburban communities. So what is clear, I think, though, is that the story, as always, is more complicated than we can summarize nationally, looking at these aggregated numbers, these data across large-scale areas, and that these aggregated data often mask some deeper problems that might be occurring at the local level. So with that background, I want to shift now to presenting some data from our research in Baltimore. So given these changes that we know are occurring in opioid use, sort of broad scale across the country, what is the impact on overdose, both fatal and non-fatal, among a population that's at very high risk, specifically people who inject drugs? Secondly, we asked, how do shifting patterns of use then impact the potential for HIV transmission that we might see locally? So what I'm going to do next is just introduce some more local level data, first from Maryland, and then we'll look at Baltimore more specifically. And then I want to introduce you to the ALIVE study. So the ALIVE study is an observational cohort study that has been ongoing with a standardized set of methods since 1988. And this really does give us the ability to look at how these trends have changed, both in terms of use and overdose over time within this local setting. So for those of you who don't know our fair charm city, Baltimore is the most populous city in Maryland, with our recent census data indicating a total population of just under 600,000. About 2/3 of the city is African American. Baltimore is a post-industrial city where shipping and manufacturing led to population booms throughout the 1950s. You can see here on this graph. I don't know if you can see my cursor. Technological challenges here at the bottom of the slide. And then following that was a steady decline in population along with deindustrialization and white flight. Here in the upper left, I actually show one of the original redlining maps of the city, which was provided by the JHU Sheridan Libraries. And this really does show how entrenched decades of segregation and underinvestment in our densely populated city neighborhoods really began. So this map is from 1937. I think these historical trends really do dictate much of the deprivation that's pervasive throughout our city. We now have about 20% who are living in poverty, according to the federal poverty definition. We have high levels of unemployment and, of course, incarceration, which is not an unrelated issue to the topic at hand. So Baltimore's heroin epidemic began, as I mentioned earlier, in the 1960s. And along with the rise in heroin use was an increase in injection drug use. So there's really limited data on the actual numbers of people who currently inject drugs in Baltimore, and recent estimates do hover somewhere around the 20,000 mark. But regardless of the exact number, there have been several studies, including this one from 2008 that was published in the Journal of Urban Health, that provides some evidence the magnitude of injection drug use per capita is greater than nearly all other metropolitan areas in the US when adjusted for population size. So it's clearly an entrenched problem here. So going back to looking again at some overdose data, this here I'm presenting is the number of opioid-related deaths that occurred in Maryland, and it's broken out by substance. It's from 2007 to 2018. And what we see in Maryland very much reflects the trends that we observe nationally, although the contribution of heroin and fentanyl over prescription opioids, I think, is really actually quite apparent here in the more recent years. When we look specifically within Maryland at the regions that are most affected, what we see is that there's a mix in terms of the burden across rural counties such as Allegheny and Caroline, and urban areas such as Baltimore City. In fact, when you look specifically at the absolute number of deaths due to fentanyl within the state, it is overwhelmingly a problem in Baltimore City and Baltimore County. And in Baltimore City alone in 2018, there were 758 deaths due to fentanyl. So the question becomes, is there a disproportionate burden then among people who inject drugs? We hypothesize that there would be, given the efficiency of this route of administration and the severity of drug dependence that usually corresponds with injection drug use. And the second question we wondered was, are there certain characteristics that might be associated with overdose in this population that we can discern using the ALIVE data? So to answer these questions, we turn to ALIVE. So again, ALIVE is a single-site, community-based, prospective observational cohort study that's based in Baltimore, Maryland, ongoing with a standardized set of methods since 1988. ALIVE has had 5 periods of open enrollment over time to replenish the cohort, most recently between 2015 and 2019. Our recruitment efforts are centered around community-based street outreach, which is important because this means that we're not restricted to people who inject drugs who may be engaged in certain care or services, and gives us a real sense then of sort of the reflection of the characteristics of the population more broadly. Follow-up occurs semi-annually with data collection focused largely on behavioral surveys and surveys about healthcare utilization as well as medical records abstraction. We do some physiological assessments as well as laboratory assessments as well. We determine death through linkage with the National Death Index. And over time, the cohort has enrolled over 5,500 people who inject drugs. The inclusion criteria is just 18 years of age or older with a history of injection drug use in the prior year. We have an active follow-up approximately 1,400 people who inject drugs at any given time. And HIV incidence in the cohort has declined rapidly over the years of the study and is now about 1% per year, while mortality has remained relatively stable over these many decades at around 2 to 3% per year. So this provides just a glimpse of the characteristics of the active cohort. It is an aging cohort. The median age at this point is about 56 years. 1/3 of our participants are female and 3/4 are African American. We have a relatively economically vulnerable population with 72% living on less than $5,000 of income per year. About half have a high school education. And while nearly 80% of our cohort is hepatitis C antibody positive, about 1/3 is HIV positive. Our HIV positive cohort actually generally shows less risk behavior and active substance use. And we hypothesize that's because they've sort of been engaged in care and services more rigorously over time, certainly since the 90s. Anywhere between 50 and 60% of our cohort is receiving medication for opioid use disorder at any given visit. So to answer our first question about the burden of fatal overdose within this population, what we did was we restricted this analysis to participants who were in the cohort, had enrolled during any of those 5 recruitment waves, and were alive in 1998, which is when we kind of started the analysis. We excluded the earlier years just because deaths due to other causes most often related to HIV sort of interfere with our ability to look really closely at overdose rates. We collected data on overdose through 2018, and this again was through the National Death Index, and we classified deaths according to drug poisoning or other drug-related deaths. We then examined fatal overdose rates by calendar year, and censored at the time of death for other causes of death, with administrative censoring at the end of the calendar year for any of those who were still in follow-up who had not had the event of interest. So unfortunately, this type of analysis, we're a little bit limited in terms of what covariates we can look at that are related to death, in that we include anyone who had ever enrolled, and we examine death kind of regardless of whether or not they were in active follow-up at the time of their death. So we may not have sort of complete recent covariate information on anything that might be time varying or changing over time on these participants. So what we decided to do was be really conservative and just look at time fixed covariates. So here we looked at just age, race, sex, and HIV status according to their last follow-up visit. And we can see that the median age and the proportion of female participants were quite similar, comparing HIV negative and positive here, with a slightly higher percentage of those who were living with HIV being African American. So here are the temporal trends in fatal overdose within Alive from 1999 to 2018. And the first thing I want to call out your attention to or point out here is the scale. Note here that we're looking at deaths per 1,000 person years. And so we can see that the fatal death rates due to overdose in Alive fluctuate somewhat, but I think are relatively stable between the years of 1999 to 2010, which sort of corresponds to the CDC's first wave. And these are the deaths that we would say would be due to prescription opioids. So it doesn't look so much like there was that much of an impact from those deaths within our cohort during that time. Interestingly, and kind of odd, is that the death rates during CDC's second wave, which is those that were related to heroin, looks like we had somewhat of a decreasing trend, and that's between 2010 and 2013. So that's kind of curious and interesting. What we can clearly see, however, is the steady increase in deaths from that time, 2013, all the way through 2018. So what we did then was we examined factors that were associated with death, but we restricted only to the 2014 to 17 period. And what we saw was that death was associated with HIV status, older age, and male sex, but that there were no differences here observed by race. So the next thing we did, on the other side of the coin, of course, is the co-occurrence of non-fatal overdose. So non-fatal overdose is a risk for a subsequent fatal overdose, which is why it's particularly of interest and can potentially give us some more insight into the trends that are occurring within this population, given that it's a more frequent event than fatal overdose, and we would be able to characterize more using covariate data. So we looked at data among participants from 2014 through 19, again, to correspond to this third wave period, who had provided some information to us on their experience of non-fatal overdose. And those surveys focused on questions about overdose only among those who were actively using substances. And so we restricted to those who had reported any use of heroin, cocaine, speedball, or any non-medical use of prescription drugs by any route of administration. It doesn't really make sense to look at overdose rates among folks who are not currently using. And so then we examined the rates of non-fatal overdose by calendar year and employed Poisson regression analysis to look at time trends and associations with demographic characteristics and substance use behaviors from the prior 6 months. So here's our study sample for this part of the analysis. It included 1,052 people who inject drugs with over 4,000 visits. It's about an average of 4 visits per participant. The sample was generally reflective, again, of the underlying cohort, which we just looked at, with approximately 2/3 male, 3/4 African American. Interestingly, about 13% had residential locations that were outside of Baltimore City, and about 1/3 were HIV positive. You can see here the recent substance use behaviors. So these are behaviors from the prior 6 months, where approximately 60% report having injected any drugs, and then 3/4 having used any recently used any opioid. About 1/3 had a recent visit to the emergency room. 26% reported recent use of the syringe exchange program. 2/3 had engaged in some sort of or form of drug or alcohol treatment. 17% were homeless, and 40% reported experiencing some major depressive symptoms. So we look at the trends in non-fatal overdose. Again, note the scale here. This is now non-fatal overdoses per 100 person years. And you can see there's some similarities to the trends that we saw in the fatal overdose with sort of these initial potential declines or relatively stable rates from 1999 to 2005, all the way actually through about 2014, where from that point on, you see that really exponential and increasing trend. And so the estimates actually showed that the rates in 2019 were 8 times higher than what we saw in 2014. And this is after adjusting for age, race, and sex. So looking more closely at the differences by demographic characteristics, here I'm going to show just some unadjusted results. We didn't see any statistically significant differences in non-fatal overdose rates by age, race, sex, residential location, or HIV status. I didn't even show those in the figure here. But we did see differences in terms of behavior with injection drug use, and not surprisingly, any opioid use associated with between 4 and 6 times the rate of overdose. And then we saw a somewhat modest association with cocaine use. In terms of some additional unadjusted associations, we saw that those who reported a recent non-fatal overdose were also more likely to have used specific services, including the emergency room, the syringe exchange program, and drug treatment. But given the lack of clarity in terms of the temporality of these relationships, in other words, that overdose may have caused someone to then engage in treatment, we excluded these variables from any additional analysis. When we look at sort of more structural and mental health factors, we see that homelessness and depression were both associated with a doubling of non-fatal overdose rates in the population, and that there were some positive associations observed with suicidal ideation, although these are fairly wide confidence intervals. When we looked at adjusted models, we decided to stratify by race to see if there might be differential risk factors for non-fatal overdose occurring by race within the study population. One noticeable difference was that the rate of increase was actually higher among African American people who inject drugs over this time period, so 2014 to 19. So 50% year over year increase compared to more modest increases that we saw among all other races. Here we just group all other races. It is predominantly white, though, in the comparison group. We also observed that African American people who were injecting drugs that lived outside of the city were actually less likely to report a recent non-fatal overdose. But we did see that depression increased risk. And for all racial groups, not super surprisingly, we did see that injection drug use was the strongest predictor of non-fatal overdose. And then a relatively modest positive association was observed with buprenorphine treatment among our non-Black population. So now that we looked at this first question, I want to shift gears just a little bit to reflect on the second before we then integrate some of these findings and put them into a little bit more context. So our second question was really focused on how the demographic shifts in the patterns of opioid use across the nation have potentially impact the potential for HIV transmission. And as part of this analysis that examines changes in who is using and what they are using and how they are using it, it's critical to the work of epidemiologists who are concerned with HIV and hepatitis C transmission to really focus on injection drug use as, the most efficient route of spread for these pathogens. And so the question is, do the changes in overdose that we see reflect underlying increases in injection drug use? And so this paper published recently in JAMA looked at national level data from the national surveys on drug use and health to examine whether there are notable increases in heroin injection that have gone along with the increased use of heroin and heroin use disorder from 2002 to 2018. And they did find that there were increasing trends in all three of these outcomes over those time periods. An increasing prevalence of injection on the population level indicates that we should continue to be concerned now about a subsequent increase in HIV incidence among this population. In fact, we've already seen pretty rapid increases in hepatitis C transmission, which along with overdose certainly does predict that there should be rises as well in HIV incidence among populations of people who inject drugs. So we also want to understand how the shifts in the types of drugs that people are using may have an impact on the potential for HIV transmission. So this analysis within ALIVE looked at the trends that we're observing nationally to see if they showed up sort of in our cohort. And what you can see, it's a little bit of a complicated graph here, but you can see the initiation route into drug use by birth cohort, as well as the recruitment period that they were enrolled into the study. And what you can see is that over time, over the birth cohorts, over time, individuals were more likely to initiate their use, their drug use by prescription drugs, and that these changes are more pronounced for those who were recruited during the later years of this study. So this is interesting because even with no changes in our recruitment methods, sort of standardized, stable methods, what we're noticing is that ALIVE is recruiting people who inject drugs that have different pathways into injection drug use than we saw in the past. So less likely to start drug use careers with injection drugs or illicit drugs. And so this suggests to us that we're potentially expanding our study population beyond this core population of heroin injectors who are historically based within the city center in Baltimore. And you can really see that reflected in the changing demographics of the cohort. So this, again, is looking at ALIVE participants by recruitment period. And what you can see is that over time, we have recruited lower proportion, of African American people who inject drugs later in our study period. So it goes down to about 55% in our 2015 to 18 enrollment period. And interestingly, and similarly, whereas in 1988 or 1989, only 3% of our participants reported living outside of the city center, 14% now come to us from suburban or rural surrounding communities within the Baltimore region, metropolitan region. So we believe that these changes in terms of the initiation of use and the demographics of our participants really do reflect some of the larger scale changes that we're observing in terms of opioid use that are occurring nationally. Here's a map of the state of Maryland, and we're just blowing up here Baltimore County and Baltimore City. So that sort of, I don't know if you can see my cursor, probably not. That line or that boundary is Baltimore City nested within Baltimore County. And each blue dot here is representing the residential location of a newly recruited participant. And this was from the years 2017-18. So you can see that whereas in the past we'd be really densely packed into East and West Baltimore, we're now kind of spreading out across the county. And the fundamental question then for us as related to HIV transmission is how much connection do these populations have to one another? We're sort of thinking that we're tapping into now multiple populations of people who inject drugs who have sort of different historic pathways into injection. And we're wondering, are these communities or networks connected? Is there the potential for shared drug use across these urban and suburban geographies within Baltimore? So because several HIV outbreaks have followed the course of the opioid epidemic in the US, there's several factors at play here that would cause us to be concerned. So most importantly, we want to think about the context within which we would most likely see behaviors that are most likely to transmit HIV and hepatitis C in this population. And we know that several structural and social factors influence the most important behavior, which is sharing of needles and syringes. And these include limited access to supplies of sterile and clean syringes, as well as economic instability, factors related to the neighborhood environment, including deprivation and disorder, and then social network factors and relationships between people who inject drugs. So interestingly and critically, synthetic opioids may actually lead to higher risk injection practices. And that's not only due to the physiologically shorter half-lives that synthetic opioids have compared to other opioids, which leads to increased frequency of injection, but also scarcity of resources that might lead to more frequent sharing of needles and syringes among people who inject drugs. So we have actually seen this now in a couple of isolated settings within the US. Outside of Boston and Seattle, we've seen some HIV outbreaks that were really fueled by synthetic opioids, and as well residential and economic instability among populations of people who inject drugs in those communities. And interestingly, the other concern is that the same factors that might be driving behaviors or higher risk behaviors that are related to injection drug use are also those that might lead those who are living with HIV to be less likely to be perfectly adherent to their antiretroviral medication, disengage from their HIV care, and then more likely to suffer treatment failure, which then of course suggests that they're more likely to then to not have viral suppression, meaning that they're more likely to transmit the virus should they engage in these higher risk behaviors. So we know also that in Baltimore, resources for safe injection remain limited outside of the urban environment, despite some of the data we've just reviewed. And so in non-urban areas, we see that they're less likely to have access to clean needles and syringes. Despite this, they do have a lower HIV prevalence at the moment. And this might just be to shorter amounts of time or shorter lengths of time that they've been injecting drugs. And we do know from previous research that social networks rather than geographic proximity, actually has more influence on injection practices within this population. So now we want to ask, to what extent is there interaction between people who inject drugs across these urban and non-urban geographies, given the context outside of urban settings where there might be limited resources to support safer injection practices? So what we did was we nested a social network survey within the Alive cohort to kind of look at whether there was overlapping social networks from folks who lived in these different parts of our region. So we collected data from participants who had reported injecting at all in the prior 12 months, and we asked them questions specifically about their drug use network. And then we looked specifically at the residential location of the respondent and looked at their drug use ties and the residential location of their ties to see whether there were discordant network members. So folks who lived in the city, for example, had a drug use tie that lived outside of the city. And then we wanted to understand what were the characteristics associated with folks who had these sort of bridging networks. And then we did a small qualitative study, which we might not have time to go through, but I might just mention it quickly, to really dig into the context and understand what types of relationships kind of cross these types of geographies. So here, I'm just showing really preliminary data from 238 participants. Again, their characteristics do reflect the underlying cohorts. I won't go through those. We found that just over half didn't have any ties that defined them as bridging. In other words, their entire network was centered either in the city or outside of the city. No one was sort of connecting those two networks together, but that 29% did have this discordant tie within their network. The remaining folks reported either that they used with no one, so they used only alone exclusively, or that they didn't have a residential location. So this made it really hard for us to classify the residential kind of discordance within their network. And what we saw when we looked closely at whether or not the person who injected drugs had this bridging tie within their networks, we saw similar proportions of male participants. However, lower proportions of the bridging ties were African American and less likely to have an urban residential location, suggesting then that folks who live outside of the city are more likely to interact with folks who do live in the city. Interestingly, they were less likely to be HIV positive, though none of these differences were statistically significant. What we did see in terms of statistically significant differences were in terms of some higher risk behaviors, including a higher proportion who injected cocaine, which tends to lead to more frequent injection behaviors over time. A higher proportion who reported that they inject before at least one other tie in their network. So they shared a syringe, they injected and then passed it to a tie in their network. And higher proportions who reported polysubstance use injection and use of painkillers, both of which are sort of known for higher risk in terms of sharing behaviors. So in the interest of time, I'm just going to skip this qualitative study, but I'm happy to follow up with anyone who does have interest in greater detail. Just the context is that we sort of dug into those who did have a bridging tie to try to understand the dynamics of relationships between folks who reported injecting with someone who had a discordant geographic residential location, and the types of relationships that we saw forming between across these networks. So I'll just summarize what we've discussed so far. I know it's been a lot. What we've seen from our research really is evidence that the overdose trends among people who inject drugs in Baltimore confirm this third wave of the opioid epidemic is having kind of the most drastic impact in this population. Again, we saw a statistically significant upward trend from 2014 to 19 in terms of non-fatal overdose among African American people who inject drugs in Baltimore. The social network study also demonstrated that there's overlap in terms of the social networks that span the urban and non-urban environments in the region. And we saw that those who have these connections do have some higher risk injection practices with their drug use ties. And then our qualitative data, which I didn't go over, really dug into some of the types of relationships that we saw forming within these networks. course, there's always limitations. I wouldn't be a good epidemiologist if I didn't talk about those. We might have some limited external validity here, just in terms of that our findings may not be transportable to other populations in other settings. And so the conclusions we draw may not be as relevant to people who use drugs in other locations. But we do think that we're seeing some of these larger scale trends showing up in our cohort does lend some evidence for a good amount of external validity within the cohort. We do know that there may be potential losses to follow up, and these could be related to our exposures or overdose, and that there may be some bias in terms of who was available to participate in our social network survey. But we do also think that those who are missing are probably the riskiest in terms of their behavioral profile and in terms of overdose. And so what we're presenting here would actually be an underestimate of the rate of non-fatal overdose within the cohort. There, of course, are always potential biases in terms of data collection. We think we do a good job within Alive of trying to mitigate those biases as much as possible. And then our qualitative study was limited in scope to those who did participate in our survey, and that there may be nuances in terms of geography that we just weren't able to capture that goes beyond the sample that we've included. So, whoops. Sorry about that. Okay. So in terms of overdose prevention, the implications of these findings really suggest that the current policies that are in place that are focused on increased rates of overdose really don't address the issues that we're seeing in urban areas. So I'm thinking of things like prescription drug monitoring and regulation of prescription opioids. That's likely had an impact on curtailing deaths more broadly, but the responses are doing very little to address the rising rates of deaths that are due to synthetic opioids, particularly in urban areas. So our findings support the need for increased access and integration of medication-assisted treatment, as well as naloxone for overdose reversal more broadly. Fentanyl test strips are a great intervention, but and they can inform sort of individual behavior changes for the user. Anecdotal reports from our population suggest, however, they're not very widely adopted because people believe, and I think rightly so, that fentanyl is pervasive and it's in everything. And what good is it to test? I know it's in there. I think more controversial interventions, such as safe injection sites, would actually also address the need for expanded access to overdose reversal assistance, but I know those are sort of politically charged interventions. I think importantly, addressing the mental health concerns of this population through integrated care approaches is urgently needed to address the depression and other mental health symptoms that we know are co-occurring with substance use. As far as HIV prevention, I think the implications here are that we think we've identified some precursors that may create conditions through which HIV can spread from urban to non-urban people who inject drugs in our region. And we think this indicates that an expansion of syringe exchange programs in non-urban communities is urgently needed. And as well, through the qualitative study, we did identify one type of relationship that was called a guide that we think may actually be useful to leverage in terms of implementing interventions outside of urban areas to improve the effectiveness of those interventions that are delivered locally. So the 1,000-pound elephant in the room is, of course, COVID-19. And, we're all extremely aware that this pandemic has caused kind of widespread disruption in our population, both in terms of stability as well as access to services, to life-saving services in some instances. And so our next steps are really to look at how the disruption from this pandemic has shaped the trajectory of overdose risk within our population, and whether or not it has exacerbated the potential for HIV resurgence among populations of people who inject drugs. So again, I did mention earlier, there's some very new and early evidence to suggest that overdose death rates have risen significantly in 2020, corresponding to the COVID-19 pandemic. We don't know yet enough about how these disruptions and lack of potential access to services have changed risk behavior, and that's really kind of the thing that we're hoping to uncover. And so our next project, for which we just actually received funding from NIDA, is going to investigate, kind of again, looking more holistically at this data, both at the individual and network level, and looking at stability to see whether or not the COVID-19 pandemic has exacerbated the conditions that would potentially lead to resurgence of HIV among this population. So I think I came in just on time. I want to thank you all for your attention and again, for the invitation to speak with you today. It's been really a pleasure to meet you all. I do want to acknowledge our funders and of course, our participants for their dedication to our study and for working with us over these many decades. And I would be delighted to hear if there are any questions to continue the conversation.